Next paper, a rare presentation of clinically and genetically diagnosed medical condition, hypophosphatemia tumoral calcinosis, and will be presented by Dr. Muayyad Abdullah Al-Sureikh. He is a fellow adult endocrinology, King Fahd Medical City in Riyadh.
Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you so much to the organizing committee. It's an honor for me to present a case in front of you and to listen to the multiple experience to this rare case of hyperphosphatemic tumoral calcinosis. Here is the co-authors, Prof. Mona Foda, Senior Endocrine Consultant, and Dr. Ibrahim Ajwa, F2 Adult Endocrine Fellow, and me. This is my outlines for this presentation. So I will start with the case presentation. This is the diagram that I will follow case presentation with the clinical presentation and genetic study and others. He is a 19-year-old male presented with 2 months history of hip pain, left hip pain, and progressive swelling. No previous history of trauma, febrile illnesses, or other acute or chronic joint pains or pathologies. Limitation on his gait was observed on the first look. On further inquiry, he has multiple identical presentations to many hospitals, private and governmental, with the same presentation of multiple swelling around joints, upper limb and lower limb, mainly in the left elbow, right elbow, and left hip and right hip. History of seeking medical attention, as we mentioned, to many hospitals. Family history is negative for any syndromic features in the family or any syndromic diseases. At age of 13, he presented with the same problem in left elbow in a governmental hospital, which was treated surgically and medically. At that time, his doctor suspected a syndromic or a genetic problem, and he did the genetic study, which was showed a gene mutation in GALNT3 gene, which is consistent with tumoral calcinosis. These are the labs for him and physical examination. He was vitally stable, looks underbuilt with a BMI of 17. We consulted to see him after the surgical intervention, but examination from previous hospital notes documented a masses that has been filled around the affected joint. The laboratory findings: serum phosphate 2.1, which is high, serum calcium to the lower range, PTH was normal, serum creatinine 61, alkaline phosphatase was normal. These are the radiological study for him, and you can see here in the right panel the right soft tissue mass around the right hip without any bony destructions, multilobulated, as well as in the left panel you can see the mass around the left elbow as well. The bone is intact, but there is a multilobulated cloudy form mass, soft tissue mass. This is another CT for another radiological study, CT. Kidney shape mass you can see with septation and calcification without bony destruction. This is the pathology slide showing multiple histiocytes, multiple areas of hemosiderin containing cells consistent with the rare diagnosis of tumoral calcinosis. In hospital management, we did for him a surgical excision by the surgical team. We give him antiphosphatic medication to lower the phosphate, sevelamer. We consulted the clinical dietitian to adjust the diet, and physical and occupational therapy as well. Actually, we did not replace his low vitamin D. It was around 35, which there is an evidence that if we replace vitamin D or calcium will increase the risk of further ectopic deposition and we will aggravate the disease further. If GF23 therapy was not available, which is a phosphatiuric as you know. Definition of background: the hyperphosphatemic tumoral calcinosis, debilitating condition that affects primarily children and youth, characterized by deposition of skin, subcutaneous and periarticular soft tissue masses, and leading to limbing and multiple joint affections. HTC is extremely rare, with a reported less than 100 cases reported in the literature, last update 23rd of September 2022. And exact etiology is not well understood. There is a primary and secondary. In Saudi Arabia, this is the first report, 1995, 3 siblings and 1 cousin, female cousin, reported with the same disease. Another report was in 1997 of 3 cases, 2 of them are siblings. Here is the review of FGF23 and its action. It's amino acid that ultimately leads to phosphaturia through the kidney tubules. So loss of this function or an activating mutation lead to a reverse with a phosphate getting accumulated in the blood. So it could be a deficiency or resistance with finally accumulation of calcium and phosphate. And tumoral calcinosis can be primary or idiopathic or secondary to multiple medical conditions. Primary disorder can be normophosphatemic or hyperphosphatemic. Most of the cases reported in the literature were hyperphosphatemic. To some pathogenic variants, like our patient, it could be in 3 divisions. One of them, which is the most common one, is JLNT3, which encodes a protein responsible for FGF23 glycosylation. The second one is the mutation in FGF23 itself. Third one is KLJ mutation. Inactivating variants in JLNT3 cause a familial form, as we mentioned, and more than 40 pathogenic variants in this gene, including missense and nonsense and deletions. This is a clinical presentation. We touch on that, clinical features and the lab findings. And here is some extra articular manifestations that we can see here in the left upper panel, the CT of aorta showing calcification, panel B CT scan showing of the heart showing calcified focus in papillary muscle, and you can see in the panel C microlithiasis in ultrasound of testis, and also there is a bony affection in the oral cavity with bulbous roots shortening and obliteration. Lines of measurement in general, due to the rarity of the disease, there is no much robust data on that, only case reports and small cohorts, which the main lines of treatment: surgical excision in the first. Second is anti-inflammatory due to sometimes pain and on limping, or sometimes spontaneous pain if touching some capsules around it or some nerve endings. Third line is phosphate lowering therapies, and FGF23 is a phosphaturic but not yet available. These are the main conclusion of my presentation. This take-home messages, if I have time to go through it, or okay, hyperphosphatemic tumor calcinosis is a rare and disabling disorders. The disorder is manifested as hyperphosphatemia, inappropriately increased tubular reabsorption of phosphate, and it's rare with a genetic predisposition in most of the cases. It can be secondary to many medical conditions such as kidney failure and others. Early detection and surgical treatment with phosphate-lowering medication and diet modification is a crucial steps in managing this disorders. Unfortunately, efficacy data are limited to case reports and small cohorts, as we mentioned before, no clearly effective therapies has been identified apart from what has been done in previous case reports that be effective in reality, but there is no head-to-head comparison or ACTs on this rare entity. Here is my references, and thank you so much for listening.
We have time for one question, if there is any. In that case, we adjourn for this session, and we'll have coffee break for exactly 6 or 7 minutes. We'll be back at 3 o'clock sharp. Please don't be delayed. We have interesting session after this.